into the broader group. I too, as part of a sort of best practice personal preference for I'm going to do a shorter version. I'd like to take this opportunity to acknowledge both the First Nations and Métis peoples whose territorial land I'm fortunate to call a place to live, work, and play. Thanks for having me today. I'm particularly pleased to be able to speak with the Absporu Patient Engagement Group. The work I'm talking about today, the title of which you can see here, is from a few years ago, but that was a project that was and remains close to my heart. And so this is the bit where we sort of do a little bit of retreading. I apologize. It's an academic presentation. Us academics love to talk about ourselves. Hopefully, no, I'm not particularly interesting. We'll get through this fairly quickly. The question that comes from that, if this is close to my heart, then for whom does that heart keep beating? I'm Myles. Amongst other things, I'm a tenured faculty, as you've heard, at the Cummings School of Medicine, and the director of research at the School of Public Policy. I have a lot of school in my life. My training is as a sociologist of institutions, which is to say, I study how both piles of bricks, that kind of institution, and the values that are built into those piles of bricks shape the ways people think. Even prior to coming to the School of Public Policy, I was interested in how those institutions shape the implementation of policy. I conduct qualitative research on just that, asking, what does that look like on the ground? Whenever anyone releases a high-level policy announcement, how does it get thought about and implemented or not implemented or partially implemented? My doctorate is from the University of Toronto. I spent time as a postdoc at the University of Leicester. I gained my first faculty position as a health services researcher at Johns Hopkins in Baltimore, and I came to Alberta in 2017. Across all of these institutions, I've been asking, what does that look like on the ground? And today, I'd like to talk to you about a particular case of that. In fact, I'd like to talk to you about two cases of what does that look like on the ground, both of which led to the creation of this research article, the topic of today's discussion. So the first case of what does that look like on the ground was the instigation of the research behind this article. I wanted to understand what Canada's caregiver policies looked like from the perspective of caregivers themselves. Now that's a bit vague. So more specifically, what I wanted to understand was how our health system's reliance on informal, unpaid caregivers was being experienced by the caregivers who were being relied on. I wanted to know what caregivers on the ground were experiencing and to find out if there was anything that might be done to help them. So that's case one of what does that look like on the ground? Case two is less of a question and more of a statement. It was me and my co-authors' experience of what engagement and inclusivity policy and research funding actually looked like on the ground. Spoiler alert, this is the big take home for the paper. Our experience of trying to find out if we could help caregivers as they experience the system relying on them, our experience of that was that it was really hard to do. Despite the fact that funders and grant opportunities spoke the language of engagement, of inclusivity, of partnership, the actual timelines and points of access for making this kind of research happen didn't really support it. So I suppose with the big take home already given away, we could just drop the mic and move on. Perhaps a bit unsatisfying, and certainly not an opportunity to get into the research question that made up the first case of what's that look like on the ground. So let's keep going. I only wish I was as slick as Obama. So recall, this was the originating research question. My team and I found that much of the answer to this first part of the question could be summed up as burnt out. Caregivers relied upon heavily by health systems and social care systems to provide a full range of care were, and still are, particularly under pandemic conditions, on the brink of not being able to do much more. If we look at the second part of the question, what does that look like on the ground? We get to the user-centered design part of today's paper title. We found out that caregivers were burnt out by the health system relying on them. And so to try to see if there was a way to help, we started asking them about possible technology fixes for their predicament. Was there something high tech that would help them out? A panel or a screen or a hyperdrive or an app on their phone that would help. Now, this was already a bit of a change from how things often get done in research. Often a researcher has an idea for, perhaps even a prototype for, a panel or a screen or a hyperdrive or an app. And that researcher goes and sees how well it works in users' hands. The researchers take them to the ship and ask them if they like the lights in green and the seats in brown. This is at least partly a product of how research grants get thought about and adjudicated. There are not a lot of granting agencies or review committees who want to fund a grant that doesn't already have an idea. And frankly, the sexier and faster flying and newer that idea is, the more it's an app that doesn't exist, the more it's a screen that hasn't been before, the more likely that grant is to be funded. So researchers are quite prone to coming to the table with an idea and even a prototype in hand. This means that they're really in the business of testing usability, of asking whether you like the lights in green, do you like the chairs in brown? Testing for usability is something that already exists. It's quite different from testing the thing with the end user involved from the very beginning. This is a diagram of a user-centered design process. The key take-home is that the first step is user research and analysis. This is how we wanted to answer the second part of our question. Is there help to be offered? We knew caregivers were burnt out, and now we wanted to find out if there was anything technical that might help them. We didn't come into the room with an agenda that we thought ought to be created. We just asked them, so if something technological were to be developed, what would it look like? And more importantly, what problems would it actually be trying to address? Almost all of the action that's reported in today's paper took place between that first arrowhead and the concept design stop on the cycle, right here. It was right here that we encountered our challenges with recruiting caregivers. And it's the lessons learned about how to go about trying to recruit those caregivers that we report in the center of the paper. The paper goes on at some length, I'm sorry, about the particular approaches we took to trying to recruit caregivers into our user-centered design process. This table sums most of it up. We spent money on social and print media and got some people. We got lucky on a few connections through a geriatric clinic. And then the bulk of our recruiting success was through caregiver organizations. Well, duh, I suppose. Not so surprising that a caregiver organization, an organization that provides support and community for unpaid caregivers, not so surprising that kind of organization can hook you up with caregivers. Not so surprising that kind of organization, as we see in the paper, was the, quote, most efficient and effective mechanism for recruiting caregivers. But the thing about the well, duh moment is that it takes a lot of time to get there. The kind of time where a researcher builds up a relationship with an organization. We needed them to vouch for us, to open up their email lists to us. We only wanted to find out what would actually help caregivers. But frankly, their attitude was that we had a nice goal, but well, caregivers were burnt out and they needed to be protected rather than thrown towards researchers. We needed time to overcome this, time to become trusted. And remember, we weren't even showing up with a fully formed idea or a prototype. We wanted to hear from the caregivers what ought to be developed. And we were prepared for them to say, you know what, nothing really. This is not a problem that tech can solve. All of this means we needed a lot of extra time. Time that wasn't planned for in the original grant application. Time to build relationships with caregiver organizations so that they would then pass us along to caregivers themselves. So we could then ask whether it was worth considering technological solutions to their challenges. So we could be truly user-centric. So we could be truly sensitive to caregivers' actual concerns rather than bringing a pre-made solution to the table and seeking their approval in a sort of mini consultation. In the journal article, we argue that there isn't a lot of space for this kind of work in the way research is funded. We state the problem in the following terms. Existing funding models and grant processes tend to force researchers into solving a problem they think exists, rather than allowing them to co-define problems and co-design solutions alongside participants. Given that this is the present state of affairs, we make the following suggestion. Granting organizations should consider seed or incubation grants that facilitate not the presentation of pre-made research questions to nominally engaged patients, but rather the trust building and value aligning that are necessary for co-design. And so this is the big take home from the paper, if I were to say so at least. I'm very interested in your thoughts on this. Is it in fact a problem? And is the solution a real one? I can certainly imagine a world, quite like the one we live in, where grant applicants come up to the funding agency with patient and community partners already signed up. Why would extra time be needed to be built in if the researchers did this initial work? What purpose would the seed or incubation grant serve under these circumstances? Well, I have a response to that, but I'll hold on to it and see if there are other questions or comments or thoughts on user-centered design, the approaches we took to recruiting caregivers, or the big issue of whether funding agencies ought to structure in time for in-depth consultations. With that fairly brief presentation, I shall stop sharing